the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm your host for tonight's program on arthritis. We'd be glad to take your calls on arthritis, osteoarthritis, bursitis, tendonitis, and rheumatoid arthritis. Again, the success of this program is very dependent on you, the viewer, so please call in your questions and we'll do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Anna Fernandez, a rheumatologist with Essentia Health, Dr. Deborah Keyes, an internal medicine specialist with St. Luke's Duluth Internal Medicine Associates, and Dr. Cindy Weaver, a rheumatologist with St. Luke's Rheumatology Associates. Our medical students answering the phones tonight are Tyler Gettle of St. Clair, Minnesota, Jonathan Harvey from Long Prairie, Minnesota, and Barry Park of Ely, Minnesota. And now on to tonight's program on arthritis. It's always a few minutes before questions come in, so I think we ought to start with just some definition of terms. And Dr. Fernandez, describe osteoarthritis for us.
Osteoarthritis is probably the most common type of arthritis that we see. It is the arthritis that's associated with degeneration of the cartilage, so thinning of the joint, what we used to refer in the past as wear and tear of the joint. The patients will have spurs that occur, the cartilage thins out, and it causes pain, especially with weight bearing, for example, in a knee. This is the one that you may notice enlargement of the knuckles in the hand. Osteoarthritis is a very common type of arthritis, and it's important to distinguish it from osteoporosis because there are two different things.
Thank you. How about rheumatoid arthritis, guys?
Well, rheumatoid arthritis is a systemic disease. That's an autoimmune disease, meaning your body's immune system is attacking a number of things, and including the joint. One of the things that separates it from osteoarthritis is that it really does affect the entire body, including the cardiovascular system, especially, and as opposed to osteoarthritis, which is more joint-based and is treated very differently. Causes joint pain and swelling like osteoarthritis, but has much more devastating systemic or whole body complications.
Well, Dr. Weaver, we'll just go down the line here to start with. What about the differences between, and what are like the risk factors for arthritis?
That's a good question. When you look at the differences between those two types of arthritis, actually you guys have already answered that to some degree. With osteoarthritis is what we used to call sort of arthritis of aging of the joint or wear and tear arthritis, and the cartilage wears out or the cushion in the joint wears out. It has not so much to do with being attacked, but sometimes you can see it with injuries. For instance, a football player that injures their knee, 20 years later they come to see us as a patient because their knee is worn out. On the other hand, rheumatoid arthritis has more to do with your immune system attacking you. So it really has, the immune system starts to attack the joint as though it was something foreign, like a bacteria, and then can cause destruction of the joint itself. For risk factors, that's actually a very good question. The biggest risk factor, probably for osteoarthritis, is old injury or weight. You double your risk of getting osteoarthritis of the knee for every 20 pounds you weigh over your ideal weight. So I guess that puts a lot of us at risk for that. And actually we think about fat cells as just being something that just lays there, doesn't look so good. But on the other hand, fat cells actually produce a lot of things that cause inflammation and probably even cause bone spurs to grow. For instance, leptin, which is something that fat cells produce that has to do with appetite control, causes bone spurs to grow. From the standpoint of rheumatoid arthritis, you inherit the genes that make you much more likely to get that, obviously, and we see it running in families. But one thing that they've recently discovered is that smoking is one of the things that increases your risk for rheumatoid arthritis, maybe as much as 10 times. So if your kids ask you what they can do to help getting arthritis, like other family members, tell them not to smoke.
Excellent advice. Dr. Keyes, how about gender? Does gender have a bearing on arthritis?
Absolutely, and actually for both kinds. We commonly think of women as being more at risk for autoimmune diseases in general, those body immune system attacking itself. And that's very true. So lupus and rheumatoid arthritis, thyroid disease, those kind of diseases, women are much more likely. But it's true of osteoarthritis as well. Women are, I believe, between 2 and 3 times as likely to develop osteoarthritis as men. So we women are really at higher risk for both types.
You see, for rheumatoid arthritis, it's about 3 to 1 women to men. Things like lupus, probably 9 to 1.
Right. Much higher.
Can't change that.
No.
So, Dr. Fernandez, how about exercise? I know oftentimes women and men both want to know, if I exercise more, can I prevent arthritis?
I think exercise is very important for patients who have arthritis and patients who want to stay active to prevent an arthritis, particularly starting at a slow program, gradually building up, doing quad muscle exercises, which are the exercises of the thigh muscle to strengthen the knees. I think it's important that we maintain an exercise routine because that will help us keep our weight under control. And that would be one way to prevent the development of the osteoarthritis. For our patients who have inflammatory arthritis like rheumatoid arthritis and lupus that has been mentioned, if they stay active, they tend to do better. They feel better, they have better balance, they are able to have less pain. So exercise is really very important as an overall package for most of our patients who have arthritis.
Dr. Weaver, how about, before we just finally have some questions here, but foods for arthritis, or are there any certain foods that we could eat or that would improve our symptoms of arthritis? Let's say osteoarthritis.
Okay. Actually, I have to say, and you probably find that too, that's a question I get asked many, many times in a day. If there's any magic foods for arthritis, and there's been books written on that particular subject, actually a lot of books. But from the standpoint of arthritis, there probably isn't any magic food. I wish I could tell you that there's a magic food that would make it all go away. There are things, though, that probably make a difference. There are certain foods that probably are more pro-inflammatory. For instance, McDonald's. A diet that's high in fruits and vegetables, in low-fat dairy products, lean meats, the same thing you'd eat for your cholesterol, is probably the things that are going to make your arthritis better as well. Also, it's important for a lot of our patients to also get adequate doses of calcium and vitamin D. If you have an autoimmune disease, you're much more likely to get osteoporosis or thinning of the bones. And we recommend adequate doses of vitamin D. If you test people in this area, about 50% are going to be vitamin D deficient. And so usually we tell people that they need to take probably around 1,000 international units of vitamin D for calcium intake in order to get what you need. 3 servings of dairy products daily, or a calcium supplement, which is probably about 1,000 milligrams of calcium.
Oh, good advice. Dr. Kai is asking, from Duluth, the caller is asking, what causes bone spurs?
Well, bone spurs have been mentioned a few times here already, and what bone spurs are the body's reaction to inflammation. And when the joint is inflamed, we only have a few ways that we can react. Swelling is one of those ways. So in osteoarthritis, you'll see a swollen knee. Warmth is one of those ways. It may feel warm to the touch. Those are the acute or short-term consequences, but over time, with that inflammation, the bone develops extra growths. So it's basically funny little growths off the edge of the joint. And those growths are an important part of why we develop pain from osteoarthritis. And unfortunately, those are not really reversible. And so that's one of those things that we do try to prevent, if possible, with the prevention of inflammation.
Thank you. I have a caller from Bovi, Dr. Fernandez, about glucosamine, which probably is a common question that you hear, and if it's effective for Osteobiflex.
Glucosamine is an over-the-counter supplement that has been around for a long time and actually has been studied by the National Institutes of Health for osteoarthritis. And if you look at the study, that particular study, it did not differentiate from placebo, which means that it was no better than our patients taking a sugar pill. The only issue is that there was a subset of patients in that group with osteoarthritis of the knee that did report improvement in their stiffness of their knee and their pain. And so while it is difficult to say that it will stop their arthritis, or if you look at the bottle that it will reverse or rebuild your cartilage, there are some patients that do notice a benefit, less stiffness associated with the use of the glucosamine in doses of about 1,500 milligrams a day. And if you want to try it for 1 to 3 months, but if it's not working, then you can discontinue it.
Yeah, I would say the same thing. The GATE trial was the name of the study that was done, and it's been 6 years ago, maybe? More than that. And what they looked at was looking at glucosamine alone, glucosamine plus chondroitin, and then also versus Celebrex. And that with that study, they then measured x-rays of the knee to see if it helped to prevent further progression of osteoarthritis. And what they found with that, no difference, no matter what you took. Didn't make any difference. Your knee still wore out, same problem. And so it probably doesn't prevent progression. But just like you said, they did find that in a subset of patients, about a third of patients found it probably worked about as well as the Celebrex did. And so I think it's worth taking, but you have to take it for a while. And that also means that you have probably about a 2/3 chance it's not going to work at all. So
I think one thing that's important to realize is it's not really an as-needed medication, like taking ibuprofen when you hurt. It really needs to be taken 3 times a day for a good month or two. I usually say 2 to 3 times a day for a good month or two to know if you're going to have benefit.
actually, they probably even recommend 3 months before you find out whether it works or not.
And sometimes patients may say, it's not working for me, and then they stop the medication, and all of a sudden they realize that they're more stiff and they're not as limber as they were, and so that would be the indication that it is doing something for them.
All right. Dr. Weaver, I have a caller from Hayward. Cortisone injections. It did come up about the success with arthritic joints, and is it for osteoarthritis, rheumatoid arthritis, or both?
Yeah, that's a good question. And cortisone injections are something that we probably do a lot in all of our offices. And what cortisone does is it very strongly suppresses inflammation in the joint. So it probably works for really just about anything for arthritis. I mean, it helps gout patients. It can help bursitis or tendinitis. It can help osteoarthritis or rheumatoid arthritis. But it's only probably going to help the joint that you inject. And I guess probably the other part of the question that they may not have stated is it something that's harmful? There's always risks with any medication, but the risks are probably relatively small with a cortisone shot. It is cortisone, but it stays pretty much inside the joint. There's always a risk that if you have diabetes, it can make your blood sugars higher for a few days. Anytime you break through the skin, there's always a chance of infection. We tell our patients that they can have an injection depending on other medical problems and other risk factors, maybe every 3 to 6 months if it's necessary. For instance, if you're an elderly patient, you cannot treat it in another way. For instance, you can't take a lot of other medicines for it because of other health problems, or they're telling you they can't replace your knee because you have too many other medical problems. A cortisone shot might be something that's helpful.
All right, thank you. Dr. Kais, I'm going to ask you about, this is a great question. Why does arthritis flare before weather changes? Is that true or not?
You know, medicine is a very interesting and fascinating area to work in because there are a lot of things that are true that I cannot fully scientifically explain. I think this is a great example of it. People have been telling us for hundreds of years that this happens, and so yes, I believe it's true. Truthfully, I don't know why. Barometer changes in pressure.
There were studies that were done looking at the changes in the barometric pressure for our patients, and our patients will tell us that when the weather is changing, not necessarily when we have the bad weather or when it's raining or when we're having a blizzard, but they will tell you that they can sense that change in the barometric pressure, and they do notice the flares. And as we're talking about flares, weather is one of them, but stress is another one that makes our patients' arthritis flare. If they're not exercising, if they're not sleeping properly and getting their rest, are all other things that can also make their arthritis flare. And so those you have more control over than the changes in the weather.
Exactly. That's a good answer.
Well, here's a caller from for Dr. Weaver from Cook, Minnesota. And this is about psoriatic arthritis, which we really didn't touch, but it's probably good. Is psoriatic arthritis hereditary, and is it similar to rheumatoid arthritis?
That's a great question. With psoriatic arthritis, it's one of what we call the seronegative spondyloarthropathies. And in that group, there's probably things like ankylosing spondylitis, the kind of arthritis you can see with ulcerative colitis, or reactive arthritis, which used to be called Reiter's syndrome. And we do know that there's even some gene markers that you can identify. And so, yes, it probably in some ways is hereditary. Not everybody that has it is going to be able to identify that they have a certain gene or a certain family member that had that. The gene that sometimes is associated with that is HLA-B27. And in some ways it's like rheumatoid arthritis, or can look like rheumatoid arthritis, because it has to do with the immune system attacking the joint just like it attacks the skin and causes psoriasis. And so some of the medicines that we use for that are actually very similar to the medicines we use for rheumatoid arthritis.
And Dr. Kai, is a question about gouty arthritis. Maybe
yes.
describe gouty arthritis.
Well, gout is a part of a bigger group of arthritis that we call the crystal deposition diseases, meaning our body's blood decides to deposit crystals into our joints. And there's a few different types of crystals that can be deposited, and gout is the most common. Pseudo-gout is the other major component. We have all kinds of fancy medical terms. CPP,
Calcium
anyway,
pyrophosphate
CPPD,
deposition, yes,
but
yes.
Gout is the most common, and literally what happens is crystals are deposited in the joint, and whenever there's a foreign body where it shouldn't be, it causes inflammation. The triggers for gout are widely variable. This is one type of arthritis that is more common in men. It becomes more common as you age.
The things that actually make a difference in gout are oftentimes kidney problems. Because either when you have gout, a lot of times either your body overproduces uric acid or your body can't get rid of it the way it's supposed to. And the way that a lot of times it's cleared is through the kidneys. And so people that have kidney problems oftentimes will accumulate uric acid. And uric acid is really kind of a breakdown product of proteins. Risk factors for gout, I'm sure are many.
Yeah, well, I think that there's a few things. Number one is just taking a really good look at the medication list that your patient is on, because a lot of times the things that we treat appropriately, for example, blood pressure medications, can increase your risk. Most commonly, the group of medications that we know as water pills or diuretics. But the gout is important to realize that we need to treat it not only because of the pain that the acute flare causes, but because left untreated, it can absolutely lead to joint destruction down the road. And there are a number of treatments, both orally or in pill form, and as you mentioned earlier, steroid injections can be very effective for gout. Gout is a disease that sometimes people like to diagnose by appearance, and it does have a very classic appearance, but it is important that you go in and see your doctor and actually have a test where they sample a bit of the fluid from that joint that's affected to make sure that we really do know what we're treating. Infection can look a lot like gout, and other types of arthritis can look like gout. So it's important to accurately diagnose it so we can treat it. There are some great medications to prevent gout, which are very, very effective as well.
And I think a very important point here is that gout is an acute attack of gout, which you can take care of and calm it, and you're done with, and you are feeling very well. And then there's this chronic phase of the gout that can be very destructive, and this is the easiest type of arthritis for us to be able to treat. And so it is really important that patients who have gout do pay attention, and there's a goal that we want our patients to have a uric acid level that is less than 6. And so if you are a gout patient, you need to know what your uric acid level is, and this is how you are part of the team with your doctor in making sure that you're doing everything possible so that you do not get the destroyed joints and awful pain that chronic gout is. And so that's really, really very important.
There's also probably with gout a lot of things that can be modified in lifestyle. We know, for instance, what you eat and drink probably makes a difference with gout, probably more so than any other kind of arthritis. Alcohol, particularly beer intake, is something that increases uric acid levels. They also think that high fructose corn syrup is one of the things that may also lead to the increased incidence of gout that we've seen over the last few years. Obesity, body mass index. If you have a very high body mass index, you're more likely to be a gout patient. People with diabetes, hypertension, which probably have to do with how it affects how the kidney flow is, also increase your risk. So
medications like the diuretic, cyclosporin, there are other issues,
We could have a whole half hour on gout.
We sure could.
Yes.
But it's treatable, which
Yes,
is beautiful.
that's wonderful.
That's the important thing.
Right.
That's a message.
It is. And, follow your diet carefully and watch your meds. Dr. Fernandez, a caller from Iron Range. New drugs, new medications for rheumatoid arthritis. Anything that's coming up?
I think that's very important because I think we have made the distinction between osteoarthritis and rheumatoid arthritis and gout and some of these other types of arthritis. Rheumatoid arthritis is an inflammatory arthritis that leads to destruction of the joints. And patients will recognize medications like hydroxychloroquine, Plaquenil, sulfasalazine, methotrexate, leflunomide, Areva. So these are medications that we have had now for some time. The new category of medications that all rheumatologists get pretty excited about, particularly for their patients, is this category of medications known as biologics. And so these are medications that attack the arthritis at a different level, where the inflammation is being produced, and patients are having remarkable results. And so, names to throw out a few, we have Enbrel, Remicade, and Humira that have been around now for over 10 years. Yeah. Then we have some newer medications, Simponi, Cimzia, we have Orencia, we have rituximab. So yes, there are some newer medications that are becoming available. There's more medications that are coming down the line that will also be available for our patients, all attacking the rheumatoid arthritis at a different aspect of the immune system. So it is very encouraging that our patients will have options if for some reason the medications that they're currently taking are not working. Now, these are important medications, you know, the risk of infection, risk of tuberculosis. There's some things that we do worry about, but it's very encouraging that we have some options for our patients.
Yeah, absolutely.
Dr. Weaver, a caller from Ashland. This is probably a nice question, because treatment for swollen knuckles, like when you go in to see the doctor, what kinds of things should you expect when you're coming in and you have swollen knuckles or some changes?
Well, first of all, our job when you see us is to figure out what is the cause of that in order to best treat it. I mean, when you talk about swollen knuckles, probably the most likely thing is going to be osteoarthritis or rheumatoid arthritis. And so, first of all, when you see your doctor, they're going to ask you a lot of questions about, do you have morning stiffness, which is more likely to be seen with rheumatoid arthritis. They'll look at your joint and see if the joint actually looks like it's swollen or just like enlarged due to bony changes. They may x-ray it, because there's differences that you can find on x-ray, just like you were talking about bone spurs earlier. Or they may have erosive changes, which is more like a little hole that's eaten in the bone, which you see with rheumatoid arthritis. Blood tests can help to differentiate whether you have rheumatoid arthritis or osteoarthritis. There's rheumatoid factor, which is an older test for rheumatoid arthritis, and also a newer test is called a CCP antibody, which may be a little more specific for rheumatoid arthritis, will probably be done. And then after that point, your doctor will probably talk to you about medicines. Anti-inflammatory medicines can help, of course, for osteoarthritis, and there's a whole bunch of medications that Dr. Fernandez just talked about for rheumatoid, in addition to some of the older ones we use, like methotrexate.
So a nice, simple way to just do an exam first, lots of history,
Yeah,
and lab
they'll
tests,
talk to you and ask
x-rays.
you about what makes it better, what makes it worse, what have you tried, and then exam and labs and x-ray,
Good.
and hopefully come up with an answer.
All right, a call from Bovie. Dr. Kais, about what causes tendinitis. We can probably all jump in on that.
Yeah. Well, I think it's important first to clarify that tendons are kind of the extension of the muscles before they insert into the bones. And the most common reason for us to get inflammation of that area is overuse injury. We don't have time to go through all of the other causes, but really the most common is an overuse injury. And so what we oftentimes do is simply recommend that we find out what we're doing in our lives that's triggering that tendinitis and ease back a little bit. Whatever activity that is, we can put a brace on to minimize the strain on it. Sometimes taking anti-inflammatory medications in the class of ibuprofen can be very helpful. And in more severe cases, injecting steroids can be done, although we usually don't need to get to that point. But I think the real trigger is to try to figure out what we're doing in our everyday life that's triggering that tendinitis and see if maybe we can find a different way to do it.
Well, this is probably our last question, but Dr. Fernandez, I'll direct it at you first, and then we can all probably join in here. But the caller is from Duluth asking about white raisins soaked in gin, and can that ease hand pain? But, I mean, that kind of segues into, are there other things that we can do, not just eating things differently, but are there some topical things like creams and things that we could be doing for arthritis?
Well, the gin and raisins is just a very old, shall we say, supplement that people have used. Is there any data behind it? There's very little or nothing data associated with it. Do I have patients that feel that their gin and raisins help them with their arthritic pain? Yes, I have some patients that have commented on that. I think
I've also had some patients who said simply just throw out the raisins, drink the gin, and you feel better.
Exactly. But going on to the comment of supplements, yes, there are some over-the-counter supplements that people can use, some over-the-counter rubs that have aspirin-based methyl salicylate that can be very helpful for small joints of the hands, for example. That would be something worthwhile. Some people use the capsaicin cream. You have to be careful with that because that one's hot. That's made from the red pepper, but that can work, for example, on a knee or a foot or some other areas. And there's always different supplements out there that get some publicity because they have helped with the joints. You have to be careful because some of them are not studied.
Well, thank you very much. Our time is already out, so thank you all for doing this. So I want to thank our panelists, Dr. Anna Fernandez, Dr. Deborah Keyes, and Dr. Cindy Weaver, and our medical students, Tyler Gettle, Jonathan Harvey, and Barry Park. Please join Dr. Ray Christensen for a program next week on upper GI problems, when his panelists will be Dr. Brad Irwin, Dr. Daniel McKee, and Dr. Paul Sanford. Thank you for watching. Good night.